Thank you, Dr. Mona, for your nice introduction and Abby for inviting me to update in CLL management value of remission, CLL management in 2022 fixed versus continuation therapy based on EHA, ASCO 2022 and AS 2021. This is ABV disclosure. So in next, I have plenty of time, actually 20 to 40 minutes. Good evening, ladies and gentlemen. I will take you in same contents update in CLL management, value of remission in 6 basic steps. First step is some eye-opener questions in future production in 2022. Then we'll see what we are facing challenges. And of course, I will give you solution as in 2022. And typical CLL case, I will take a one case, how CLL journey and what to remember. And I make it simplify A to G hits of CLL. Then with the same example, I will go through the real world experience using all the clinical trials, Morono trials, GLU trial, CLL14 trial, and some other trials. And we will see what is the advantage of BCL2 therapy in CLL. And then final question with you that how you predict for venetoclax-based chemotherapy in 2022. So this is just eye opener. What color is the ribbon for non-Hodgkin lymphoma? You just guess. Answer is there. Lime color. Second question is which guideline you use to treat hematology and oncology in your practice? Certainly, everybody use from ASH, ESCO, NCCN, and ESMO guideline, and we use NCCN guideline. And if answer is not there, then we use expert online. So both these things I will go through in my all presentation. You will see. So the guideline as we use NCCN. So what is the frontline therapy option in CLL? And here you can see the frontline options are you have plenty of options, all 3 to 4 novel agents from Ocala, venetoclax, Zeno, all the things are available. But this raised the question, how do we choose? Actually, there are a lot of options, but how we choose, how we sequence it, this makes us first challenge, actually. Second challenge is the burden of the disease. CLL is the most common type of leukemia and accounting about 40% of the disease of leukemia. And the important thing is it never become in remission. And for cure, it always become relapse and remission phase. Third challenge is there is high risk cytogenetics have poor prognosis. And the fourth challenge is decrease, the PF is decreased from fit to frail patient. However, solution is there. Now we have divided CLL into two disease, mutated disease, which is good one, and unmutated, which is actually challenging one. So we will see how we move from 30% survival to 90%. So we know over the 3 decades, we use RAI and some other classification. Now CLL is moving from this classification to clonal and genomic evolution that indicate that one size doesn't fit all. It has divided cytogenetics from favorable, intermediate, and unfavorable categories based on the cytogenetics and of course IgGH mutation as well. So based on this, they put the in guideline in 2022. So you have preferable option. All the novel agents are there from BCL2 inhibitor to BTK inhibitor. But the important thing is how to choose it. Again, this is the challenge. So if you go by ibrutinib, there are pros and cons for everybody. Like in ibrutinib, 5-year PFS, 70% longer follow-up, but the cons is there are off-target side effect, actually cardiovascular and hemorrhagic side effect, which is decreased seen in new generation BTK inhibitor, but is still there. And then there is venetoclax BC2 inhibitor, which is time-limited therapy. You will see shortly how do we choose in these therapies. So multiple agents we are available now in 2022. The question is, how do we sequence and stratify these therapy to ensure the outcome? So in next, so this is the solution number 5. You have to see efficacy, tolerability, and economic value. So how you see efficacy, CLL has gone through 1 to 5 lines of therapy in their lifetime. But the important thing is, which is still clinical unmet, there is need for well-tolerated and fixed treatment duration, which is very important because you have FCR and BR, that is fixed duration of therapy, but the problem is there is very short PFS, especially in IgG unmutated disease. So other option, you have to continuous therapy, but the problem is at the cost of the drug and dollar toxicity of the continuous therapy. So is there any economic value? There is need for fixed chemotherapy-free treatment duration that are cost-effective and that allow us limited budget impact and across lines of therapy, which we'll see. So you can see here, if you start continuous therapy, the problem is drug and dollar toxicity. And if you have fewer side effects, you have $5,000 per month, then more the side effects, more the patient has to pay the money in cost of drug and dollar toxicities. But there is solution. If you focus on this, this is actually fixed duration. Venetoclax, abinotazumab, only 1 year was given. Next year, you have to just free up the cost. And similarly, this is Morono trial, like first year and second year you give, then third year and fourth year is free. But if you continue BTKI, like this is acalabrutinib and CD20, you have to, and this is ibrutinib, you have to continue year 1, year 2, year 3, and year 4. So you have to pay, patient has to pay continuously. So at second, third, and fourth year, venetoclax's cost reduce heavily, you can see here. So this is the solution. And as you know, in chronic disease, I always say treating CLL is a marathon. It's not a sprint. It's a marathon means you have to make a long-term strategy. So a patient move along the treatment pathway. There is clonal evaluation, but there are still some unanswered question. You have to choose BCL2 plus CD20 or BCL2 and plus BTKI. So answer is there that more the use of effective therapy should be given in the first line is well effective as good as it is shown recently in glue trial and MD Anderson. They have shown high CR rate, more than 90% after using this one. So now questions are important when you see with the CLL, what is your goal, cure or control? Cure means never requiring treatment for disease again after single course of therapy, which is, of course, it's not possible in the CLL. But there is possibility functional cure or control means disease control that require continuous or intermittent treatment but dying of other related problems. So it means you have to good control of the disease if you have used smartly the treatment. So what is the best way to unreveal these questions? Where there is a will, there is a way, but still it's not present. Maybe in 2024, 25, there will be, you will be introduced the patient based on the PH3 mimetic therapy. Based on the mutation analysis, you will find which patients fall, which therapy you can find it. But so far, the solution is there. You can use fixed duration is attractive for younger patient and all the molecular risk factor, especially less molecular risk factor, and the patient having comorbidity and financial assistance, and fixed duration is the attractive option so far. So this is, I made some challenges and solution. Now I will go to the CLL journey, how the patient CLL journey goes. As I made a simple way, A to G hits of CLL. A means accurate diagnosis and stages and prognosis. B means before beginning treatment, check the indication. C, cytogenetic and molecular tests. Then determine the fitness for the proper drug option. See the efficacy and feasible option. Go for the guideline. Then you treat the patient. We use each step by each one. So this is case 1. 77-year male who was diagnosed CLL, and this was a long time ago. Initially, he had 14,000 white cell count with a normal hemoglobin, normal platelets, and with a small splenomegaly and cervical adenopathy, diagnosed SLL, and he has prostate cancer as well. So this is the initial presentation in 2015. You can say WBC count was high, lymphocyte high, but the important thing is platelets and hemoglobin normal. So now the question is, in 2015 to 17, we keep as there was no indication, there was no symptom, there was no cytopenia, so there was no indication to keep observation, means wait and watch. So 2 years he was wait and watch. So second number, as I mentioned, before beginning treatment, check indication. We checked indication, there was not present. So accurate diagnosis we made before beginning we check indication. Now in end of 2017, he actually developed some symptom that caused him too much fatigue and symptomatic splenomegaly and lymphadenopathy. Now 6 centimeter lymph node in the neck that were disturbing to him. Now you have C to check the cytogenetic and molecular test. Once you wanted to street treatment, you had to check IgHV and you had to check FISH as well. In this patient, it was mutated and the neutral and normal. It was checked as the cytogenetics. So what drug decision, D for drug decision. Now you have to determine the fitness. You have to check any comorbidity, functional status, echo performance. So in this patient, actually, if you go by guideline 2022, you have all the novel agent as a first line, you can use it, but we were not in 2022. We were 2017. So in 2016, actually, we have the options which we use, FCR, BR, and CD20. So if, as I mentioned, so we have two options, FCR or bendamustine rituximab in 2016. So as I mentioned, after NCCN guideline, if it don't works, then we use expert online. So if you put the data of this patient and expert, and this is CCO expert online, these are 5 expert of the CLL, and this is a self-generated app is there. So I put this patient's data, and here you can say mostly they use either CLL 14 based chemotherapy, because this is 2022, so they choose venetoclax or obinutuzumab, or they have choose actually BR. Even BR is actually marble-based chemotherapy, and even they also choose BR-based chemotherapy. So 3 people actually choose BR-based chemotherapy in 22 as well, although it was in 2017. In 2017, actually, we choose same Marble-based or CLL10-based chemotherapy, 77-year male now, mutated patient, and we treated with the BR-based chemotherapy. He tolerated very well. CBC normalized, and his adenopathy and splenomegaly resolved, so he becomes symptom-free. So here you can see the beautiful curve. It started from 2018-19. He was free of the symptom, and all the WBC white cell become normalized as well. Now, after 1 and 6 months, 1 year and 6 months, he again developed progressive fatigue, mild weight loss, and again he becomes symptom, spleen become enlarged, adenopathy was there. We checked, confirmed again, CLL was there. So now the question is 2019, what we should do for this spike of the symptoms. So CT confirmed splenomegaly, FISH confirmed 13q, and IgGH mutation was checked. It was unmutated this time. So this is the NCCN guideline. Now you can use any novel agent so far in this patient, but remember this was 2019. This was not 22 or 21. So if I put then expert online, they also they can say you use BTK inhibitor or plus minus CD20, or based on the Morono trial, which is venetoclax and rituximab based chemotherapy. So choice is you can choose it. So in this patient, actually in those days in 2019, a new emerged BTK inhibitor resonant trial was very active. So ibrutinib we started in this patient 420 milligram per day, and his symptoms subsided, and and count subsided. But after 2 months, he started palpitation and multiple atrial premature complex was seen. And that this is the actually you can see ECG, which is the evident. He has the PAC and sinus rhythms was there that were disturbing to him. So what is the guideline? If you find any ECG changes you have to off therapy, and you can re-challenge if after discussion with the patient. So it becomes sinus rhythm. You can say we off therapy 2 weeks, but after a long discussion, patient didn't agree to continue. So what is the next option now? We have used BR, we have used here now ibrutinib. Now we are in 2019. What is the option? So putting the expert online again, you will surprise to know all the expert line, all the 5 expert online. They say you continue Morono-based trial, which is venetoclax-based chemotherapy plus rituximab, because now it is the mature trial. Now, after 5 years, they have shown more than 40% they have in complete remission so far. So it is very attractive trial. Now the question is, patient in 2019, it was actually just birth of Marono trial. In those days, actually Marono trial was not active, but you can see in the blood there is publication 2019, and my patient was also in 2019. This, first time they emerged was the venetoclax as a single therapy that also has seen the PR and CR, which is very attractive in those days. Even NCCN guideline, they put you can use venetoclax as a singular monotherapy as a third line therapy. So in this patient, actually, this was third line. First line, you remember BR. Second line, we use ibrutinib, and third line now we use as a venetoclax. And this he is now currently more than 2 years. He is taking venetoclax single therapy, and he is in complete remission. So this is complete journey of the patient from 2015 till 2022, 8 years of the journey. Now his third line of venetoclax is doing great. Now, you have confidence now, switching therapy and everything. Now we'll go to second case. See, we are now 2022, 60-year female who was diagnosed CLL in India. She was given CVP therapy, but she was complicated over there, hemorrhagic stroke, and then chemotherapy was stopped. Then over the 3 years, she used to continue chlorambucil till 2018. Then she was off therapy, and recently, means 1.5, so 2 years ago, she was admitted in some other hospital with a severe anemia, fatigue, and thrombocytopenia. And she was given over the treatment over there for anemia and thrombocytopenia. Hemoglobin was 5.7, platelets were 31,000. She was referred for this history to our hospital, and it was in actually 2019 September, so almost you can say 2.5 years ago. So we did bone marrow, and bone marrow confirmed this is CLL, and the treatment option now she had received first 2 lines of the chemotherapy, or you can say only 1 line of the chemotherapy, just chlorambucil and 1 dose of CVMP. So options are available in the relapsed disease. You can use any novel agent or combination of novel agent. So we put expert online, and expert online say you have to give based on the Morono trial. All 5 experts actually recommend go for VR-based chemotherapy in this patient. So this patient was given second line therapy, VR-based chemotherapy. She finished all induction chemotherapy and maintenance 18 months in March 2020. And she has completed, I show the graph. So this is the patient who came in 2019. You can see the higher. Now this is the most updated graph of the patient. She has completed 2 years of the monotherapy. Now she has received fixed duration of the chemotherapy free, you can say, novel agent plus rituximab. Now she's off therapy of the fixed duration. The dose was given same venetoclax dose ramp up from 20 to 400 milligram for 5 weeks, then 400 milligram daily for cycle 1, and rituximab started from cycle 1, then up to 6 cycles. Then she continued 18-month venetoclax. Now she is off therapy. So this is, you can say, second line patient based on the Morono trial successful case. Now third case. 83-year female who was actually diagnosed in 2014, you can say 10 years ago, when she was actually 72 years old, CLL RI 0 score. She went to different hospital in 2016. Then in Bangkok, she went, and they found lymphadenopathy and symptomatic. Actually, they started over there rituximab plus bendamustine chemotherapy. She completed over there, and then you can say in 2017 again disease progress after 1.5 year. So there she was switched over there ibrutinib treatment. So she took ibrutinib for more than 2 years, but disease progressed because of the leukocytes and again fatigue and progressive anemia. And the most important thing is progressive lymphadenopathy over there. Now the thing is, this is the chart of the patient. Here you say it was in 2015. First, uh, marble-based BR-based chemotherapy was given. Then resonant-based ibrutinib was given, and on ibrutinib, actually ibrutinib disease progress. Now this patient is given. We started actually Morono-based trial, venetoclax and rituximab. So she has also completed. This is, you can say, the started in October 2021. Now, still, she has completed 6 cycles of venetoclax plus rituximab. Now she is on continuously taking venetoclax 300 milligram daily. Now, before 400, now she's taking 300 milligrams. She's tolerating very well, and you can see the curve of the patient is doing fine. So she has got advantage of Marono-based trial as a third line, similar example like before. Now, we have another patient, 62-year male, who has multiple comorbidity. Actually, he was seen in US, actually, MD Anderson. There he was diagnosed CLL 17p deletion, actually. And he was initially wait and watch because he was asymptomatic. When he became asymptomatic, then MD Anderson actually 2.5 years ago, there was GLUE trial was very active, and he was actually put. If you put this patient in expert online, they also say that you can give venetoclax or obinutuzumab, which is CLL 14 based trial, or you can give acalabrutinib or xenoaparutinib. So these are the two choices in first line expert online. So either CLL 14 based, which is venetoclax obinutuzumab, or elevate TN based acalabrutinib. This is expert on guideline. But so this is 4-year follow-up. You can see they have shown the very good response based on the CLL 14. However, in MD Anderson, they started based on the GLUE trial. So what is the GLUE trial? GLUE trial is actually combination of ibrutinib plus venetoclax. This is 1-year treatment, and he has completed actually 12 cycles of venetoclax and ibrutinib. So here I show the graph. This is the graph when he was started over there in MD Anderson. Then he's following to Tamam Hospital you continuously. Now he has completed 2 years of the therapy, and he's off therapy now more than 6 months. Now he's in after the fixed duration of ibrutinib venetoclax. The successful story of this patient. So now, you have seen we have gone through the journey A to G CLL, hits of the A to G CLL. And the important thing you have seen, we have gone through the 4 different patients, and mostly they have got advantage on BCL2 inhibitor. First in venetoclax monotherapy, 2 Merono based, and fourth one, last one is based on the GLUE trial, venetoclax plus BTK inhibitor. So now the bonus question is, how do you think we hurt the patient, or we hit the disease? We hit the disease by giving all the patient. And this is the one of the slide which we has provided to us to, if you can actually, these are the apps, and in the Google Play you can put on this one, and you can check the easier way how to start the medication and how to monitor the venetoclax as well. So in last 30 minutes, I tried my best to explain you the update in CLL management, what is the value of remission of the fixed duration of the therapy. So I have gone through some future prediction and eye-opener question. I have gone through the challenges and solution. And I have shown you the CLL journey, how we go through A to G, and I have given you example of the real world practice, how we use actually Bruno trial, Gilu trial, and different trials. And my question is, how do you predict now venetoclax based regimen in 2022? Now we are in 2022. You have choices. You can use abiraterone, acalabiraterone, zenobiraterone. You can use venetoclax um, uh, plus combination of optantosumab, or venetoclax plus rituximab, or venetoclax plus uh, you can use any therapy like Acala or zenobrutinib. Choices you have, just you have to keep an eye of the you have to cure, for we call it the functional cures, to as much as remission possible, as much as keep away from drug and dollar toxicity. So this is my last slide. I always say, like John and Ferdinand, that in teaching the greatest sin is to be boring. Hopefully, I didn't bore you. So I am here happy to join you, your question and answer sessions, which will be very interesting. Thank you very much. Thank you very much.